Hi everyone, we are Group I, Stuttering and Cluttering. This presentation is by Maria Fee, Sarah Reinhardt, Elizabeth Nocella, and Alexis Thomas. Stuttering is blockages, discoordination, or fragmentations of the forward flow of speech. These stoppages are referred to as disfluencies. The main aspect of stuttering is speech fluency. Speech disfluency means that there is a blockage or breakdown within speech. Some forms of disfluency are normal. For example, insertion of sounds and words like like, and are very common. The main types of disfluencies are prolongations or repetitions in sounds, syllables, and words, and pauses during speech when a problematic word or sound arises. About 3 million people, or 1% of the population in the United States, struggle with stuttering. This accumulates to about 60 million people worldwide. Stuttering symptoms within speech include difficulty starting a word, phrase, or sentence, prolonging a word or sounds within a word, repetition of a sound, syllable, or word, short silences for certain syllables or words, pauses between a word, adding extra words like like, and excess tension, tightness, or movement of the upper face or body during speech production, anxiety surrounding speech, and limited communication abilities. Stuttering can also be accompanied by other non-speech-like symptoms, including rapid eye blinks, lip or jaw tremors, facial tics, head jerks, and clenching of fists. All of these stuttering symptoms can be worsened when a person is tired, in a stressful situation, or excited. However, speaking to yourself, in unison with others, and singing can help reduce stuttering patterns. People who stutter are aware of their stuttering and feel as though they lose control when they are not able to be fluent. So they know what they have to say, but struggle with the action of saying it. Individuals who stutter use a lot of physical and mental energy when they speak. Secondary behaviors are the negative reactions due to stuttering. These behaviors are mostly shown in older children and adults. Types of negative reactions include behaviors, feelings, and attitude towards stuttering. These play a role in making the disorder more severe and difficult. Cluttering affects a person's speech by causing rapid, unclear, and disorganized sounding speech. The main concept associated with cluttering is that the speaker is speaking at a rate that is too fast for their system to handle. People who struggle with cluttering often say that their rapid thoughts surface before they are ready to speak. The results of cluttering is a breakdown of communication by causing issues with fluency and intelligibility. Specific cluttering symptoms include excessive over-co-articulation, meaning that sounds and syllables are being blended together, causing multiple phonemes to sound like they are not being said. Blending together of phonemes can include deletion or collapsing of syllables and omission of word endings. Excessive usage of normal disfluencies. These include interjections and unnecessary revisions. Ungrammatical and unexpected pauses in places they do not belong. This causes jerky or spurty speech.
As Alexis has already mentioned, the primary concern of both stuttering and cluttering is fluency. To consider the co-occurrence rates of other communication disorders, we must consider the primary cause. Neurogenic stuttering, or that caused by an injury, disease, or disorder of the nervous system, as defined by the Stuttering Foundation, does not waver in less uncomfortable situations as developmental stuttering would. Developmental stuttering presents with all stuttering or cluttering symptoms from a young age as we develop. Now that we have an understanding of some of the different roots of stuttering that Elizabeth will go more in depth in later, let's look at some of the communication disorders associated with stuttering and cluttering. Neurogenic stuttering commonly co-occurs with other acquired neurological impairments that alter communication, such as aphasia, dysarthria, acquired apraxia of speech, palilalia, and finally, anomia. And as you can see, many of the symptoms of these disorders are fluency issues that overlap with that of stuttering and cluttering, as well as such general issues with getting an intended utterance out on the first attempt. According to ASHA, developmental stuttering is known to co-occur with speech sound disorders, intellectual disabilities, and autism spectrum disorder, which is characterized by impairment in communication, social skills, and restricted behavioral patterns. Cluttering is known to co-occur with learning disabilities, auditory processing disorders, Tourette syndrome, autism spectrum disorder, and attention deficit disorder. In a 2003 study of stuttering co-occurrence in the United States, it was found that of nearly 3,000 children who stuttered, 63% had other co-occurring speech, language, or non-speech language disorders, including about 19% co-occurrence of articulation and phonology disorders. This study furthers the concept of significant incidence of non-speech language disorders, the umbrella term containing the frequently co-occurring and aforementioned learning disabilities and ASD. Many in the ASD population report disfluencies characteristic of stuttering and cluttering, even though the number of cases is rarely recorded, just the similarity of symptoms. Stuttering and cluttering symptoms can result in poor pragmatic functioning, resulting in non-communicative related disorders. Both ASD, ADD, and Tourette's are known to cause impaired attentional skills and self-regulatory behaviors. Compared to children who do not stutter, those who stutter are known to be less able to maintain or shift attention when appropriate and lower in inhibitory control. These results carry over to children without ASD or ADD, showing general co-occurrence of attentional struggles. These issues can cause disfluent speech to worsen, causing conversational partners to struggle even more to keep up. People who stutter can pick up on the confusion and become even more self-conscious of their speech, inducing a painful cycle of disfluent speech and self-deprecation, causing anxiety. People who stutter experience self-doubt and negative thoughts about themselves when it comes to being in social situations. Prevalence of social anxiety disorder was significantly higher for stuttering children when compared to non-stuttering control groups, indicating a 6-fold increased odds. There is even evidence that those who stutter in childhood and adolescent populations are bullied more than their non-stuttering peers simply because of the way they speak. Incidents of generalized anxiety disorder are also 11% higher in the stuttering population, often with one's speech being the self-reported cause. People who stutter are aware that others negatively respond to their speech. One's own view of the impact stuttering has on communication is even taken into consideration in the assessment process in such formal tests as the BAB or BAB and Kitty Cat. Along with informal assessments for clinicians to determine patient severity of stuttering, formal assessments exist such as the SSI-4 and TOCS. A comprehensive assessment is crucial as no two cases are the same, and even in the same individual, symptoms can be worse in more anxiety-provoking situations like a clinic may provoke. Unfortunately, assessments can be nerve-wracking and produce an inaccurate representation if not done properly by an experienced clinician. However, assessment is crucial to rule out other speech and language disorders. Elizabeth's sister Catherine was able to give us a report of how stuttering affected her life, as well as how intervention helped her. After years of treatment, she was able to give us some insight into how stuttering can impact even the most minor daily events.
And in high school, it was the same thing. I got pulled out of lunch, and I wasn't able to hang out with my friends. Also, ordering lunch throughout my grade school years was also difficult too, because I would have to talk fast, which would cause my stuttering to develop again. And I was always so hesitant to order lunch, where sometimes I wouldn't eat because I didn't want to order lunch if I didn't bring food from home.
I am going to be talking about the risk factors associated with stuttering. With family history, almost half of all children who stutter have a family member who stutters. The risk that a child is actually stuttering instead of having normal disfluencies increases if that family member is still stuttering. If the family member outgrows stuttering as a child, there is less risk. At the age of onset, children who begin stuttering before the age of 3.5 are much more likely to outgrow stuttering. For a time since onset, between 75 and 80% of all children who begin stuttering will stop within 12 to 24 months without speech therapy. If a child has been stuttering longer than 6 months, it is less likely they will outgrow it on their own and will need speech therapy. With gender differences, girls are more likely to outgrow stuttering than boys are. Studies show that 4 boys continue to stutter for every girl who stutters. The sex ratio for stuttering appears to be equal at the onset of the disorder, but studies indicate that among the school-age children who continue to stutter, there are 3 to 4 times as many boys who stutter than there are girls. During the same time period, family and others often react to boys somewhat differently than girls. It may be that more boys stutter than girls because of basic differences in boys' speech and language abilities and differences in their interactions with others. Other speech and language factors that are a risk is that if a child makes frequent speech errors, such as substituting one sound for another or leaving sounds out of words. And according to ASHA, people who stutter may have small differences in the way their brain works during speech. The diagram to the right shows the risk factors created by the Stuttering Foundation to help parents decide whether or not their child should see a speech-language pathologist. If a child has one or more of these risk factors, there should be some concern and a speech-language pathologist should be consulted.
First and foremost, it is important to note that treatment for fluency disorders is highly individualized. Numerous factors are taken into account when choosing treatment options. These factors include, but are not limited to, age, amount of stuttering, functional impact of stuttering, affective reactions, behaviors, and cognitions. Assessing these areas gives clinicians an all-encompassing picture of how the fluency disorder is impacting the person's life and guides the clinician to treatment options that best fit the individual. Some clients will benefit most from focusing on changing their speech patterns, whereas other clients will benefit most from focusing on the negative reactions and the affective and cognitive impact of the stuttering. Due to the multidimensionality of the effects of fluency disorders, there will likely be numerous treatment targets used in a comprehensive approach. Clinicians use evidence-based practice combined with their own clinical expertise and client preference to inform their decisions. Service delivery for fluency disorders will also be individualized. Treatment of fluency disorders is a dynamic process, and service delivery is likely to change as client needs change. Next, Catherine will discuss her experience with service delivery in a group setting.
In high school, I started with a group, and then it eventually went on to one-on-ones up until junior year, where I would sit with my speech teacher, and I would mostly help another student as well, and some of the exercises that I learned throughout the years and helping them. I thought it was a great experience for me, and so other students can see what other students did that helped them with their stutter opposed to what they learned throughout elementary and middle school.
Generally speaking, treatment goals for fluency disorders fall within 3 domains. First, impairment of body function refers to goals related to increasing speech fluency and reducing the severity of disfluencies. A goal within this domain includes reducing the frequency of disfluencies. Second, activity, limitation, and participation restriction refers to goals related to improving functional communication abilities across contexts. A goal within this domain includes increasing the client's ability to communicate effectively in various speaking situations, thus prompting them to participate in these interactions. Last, personal and environmental context refers to goals related to improving coping responses as well as reducing negative responses from others in the environment. A goal within this domain includes reducing negative emotional responses to communication. Generalization and counseling activities are also extremely important. Focusing therapy on activities that can be generalized to real-world situations gives clients the tools they need for success outside of therapy. Additionally, discussion of positive and negative communication experiences can be important for reframing a client's thoughts towards communication, as well as for improving acceptance of the disorder. Early identification and subsequent early intervention in the treatment of stuttering is critical, as complete recovery is most likely when treatment is started close to the time of onset. When concerning young children, the focus of therapy is to eliminate the stuttering and to prevent any social, emotional, or psychological problems associated with the disorder. The goal of therapy is to facilitate natural recovery, as stuttering does typically diminish with age. There are two main routes for the treatment of young children, direct and indirect, and the two can be combined into a single treatment program. Direct strategies target the child's speech itself by teaching skills that will help improve fluency. Speech modification and stuttering modification exist within this category. Speech modification refers to strategies used to reduce the amount of stuttering. Strategies used may include fluency shaping, rate control, continuous phonation, prolonged speech, and easy onsets. Fluency-enhancing strategies include techniques that alter breathing, speech rate, voice, and articulation in ways that facilitate more fluent speech. Second, stuttering modification strategies help students to increase awareness of stuttering, reduce physical tension, reduce negative reactions, and increase feelings of control and acceptance. The goal is for the child to stutter more easily. Techniques used include cancellations, preparatory sets, and pullouts. Indirect methods focus on altering the environment to give the child more opportunities to develop fluent speech. It is argued that efforts to modify the environment by reducing the cognitive and linguistic demands placed on the child will result in improved fluency. Caregivers are often counseled on how to reduce speech demands by using techniques such as speaking more slowly and pausing more frequently. Conclusively, choosing between direct and indirect methods is dependent on the child's awareness of and concern about his or her disfluencies. Next, Catherine will discuss a treatment strategy that she used in elementary school.
And there was one specific exercise that we did where I would have to start at one end of the tape and go to the other and finish a sentence. So, for example, if the sentence was, today is October 9th, 2020, I would start at one end of the tape and say, today is October 9th, 2020. And I would have to start the sentence at the tape and end it at the tape. And this was difficult sometimes because I would talk fast, so I had to make sure that I was getting across the tape.
As the child ages, it is less likely that the stutter will completely recover. This is why treatment for older children, adolescents, and adults all looks fairly similar. Stuttering is likely a chronic problem, which is why focus is on developing positive coping mechanisms, management, and reducing tension in real-life social situations. Internal motivation and external support systems also play a vital role in coping with stuttering. Clinicians form person-centered functional goals with each client that depend on what is important to the client at hand. Smooth speech, also called prolonged speech, has been shown to improve stuttering in this population. This technique is a fluency-shaping approach that includes a reduced speech rate, continuous phonation, prolonged words or sounds, and breath management. The goal is for speech to sound as natural as possible. Last, cognitive counseling should be considered. Oftentimes, this counseling component is the most essential treatment area. Becoming comfortable with talking about stuttering is crucial, as it will be difficult for the individual to feel comfortable managing stuttering if he or she is constantly trying to hide it. Last, treatment considerations for cluttering are typically centered on techniques that regulate speech rate. An example of this is increased pausing. Pausing has been found to be effective for improving speech intelligibility and fluency. Another strategy that has been found to improve intelligibility and overall speech clarity is overemphasizing multisyllabic words and word endings. Increasing self-regulation of rate and clarity of speech is also important. In conclusion, these disorders are more than just disfluencies. They include tension and negative feelings about speaking, which can have great impact on a person's life. Stuttering and cluttering are both known to co-occur most commonly with attentional issues, literacy disorders, language disorders, and APD. Stuttering brought on by brain impact can also occur with neurological speech disorders. All types of stuttering and cluttering are known to relate to social anxiety. Assessment of fluency disorders is conducted both formally and informally, and there are numerous risk factors that should be taken into account during this assessment process. If identified as in need of services, early intervention is important in order to increase the chances of a full recovery. A comprehensive treatment approach incorporates many facets, including speech modification strategies, improved knowledge of stuttering, improved reactions to stuttering, decreased physical tension and secondary behaviors, and overall improved communication. Thanks so much for watching our video on stuttering and cluttering.